Hello and welcome to this brief video on medication review. This is from the Department of Family Medicine at RCSI Perdana, and I'm Professor Anthony Cummins. This is an outline of this video which begins with some learning outcomes. Then we look at different types of medication review and ask the question, why do medication reviews? And if it's important to do them, how often should we do them? And crucially, what should be considered when undertaking a medication review? We then look at potential inappropriate prescriptions. Hello and welcome to this video on medication review. This is from the Department of Family Medicine at RCSI Perdana, and I'm Professor Anthony Cummins. This is an outline of the video. We'll begin with some learning outcomes, and then look at types of medication review, different types of review, opportunistic review, clinical review, etc. And then we'll pose the question, why should we do medication reviews? And if we do conduct them, how often should they be done? And crucially, what should be considered in a medication review? We'll then look at potentially inappropriate prescribing, particularly in the elderly. And we'll then have a brief look at the prescribing cascade. There are various criteria to improve the safety of prescribing, and the two most widely used nowadays are the stop-start criteria. We'll then look at some commonly prescribed drugs with preventable harm and run through some sample medication reviews before providing you with some references for further reading. So having completed this video, you should be able to complete a medication review with the patient, and in fact you will be required to do this as part of your assignment portfolio for SC1 Family Medicine. You should be able to outline the impact of multimorbidity and polypharmacy on drug adverse events. You should be able to discuss the importance of regular medication review in particularly vulnerable groups such as the elderly. There are several types of medication review. There may be an unstructured opportunistic review. For example, during a consultation, the GP feels that a particular medicine may not be appropriate and then may discuss that briefly. But this is not a structured review, and it's purely done as it arises during a consultation. There may then be a technical prescription review where the doctor looks at, for example, a repeat prescription at a time when the patient has requested the usual repeat list. The doctor may review this and think one of these may not be appropriate and make changes appropriately, and make changes accordingly. There may then be a formal treatment review where the patient's full notes are available and the doctor cross-correlates the medication with the patient's notes. The drawback of all of these three types of review up to now is that there is no patient involvement. And with the patient present, you then get an idea about concordance, adverse effects, understanding of medicines, and so forth. So why are they performed? Excuse me. Well, typically because many elderly people take several medications. And certainly it's known in the Western world over 36% of over 75-year-olds are taking at least 4 medications. And therefore potentially inappropriate prescribing is prevalent. Also, patients' beliefs about medicines may hugely affect how they take them, how regularly they take them, and so on. A well-structured clinical medication review has the potential to involve the patients so they're much more actively involved in their care. Otherwise, it's simply a very passive experience, taking medications on a daily basis, but not having any realization of why you are taking them. So the involvement improves concordance, and that improves prognosis and outcome. Taking safe medications helps people to maintain independence by getting rid of drugs that are potentially harmful. You can clearly detect adverse drug reactions by discussions with the patient, and you may delay complications, for example, such as admission to hospital or care homes due to inappropriate prescribing. Increasingly now, not alone is polypharmacy, or the prescription of several medicines to elderly patients with multimorbidity. Not alone is it implicated in hospitalization, but it is now implicated also in increasing mortality. So elderly patients die because of drugs prescribed by doctors, and that's an important consideration. There is also the potential to generally improve outcomes. So if patients are given target dosing for drugs such as ACE inhibitors for hypertension or heart failure, their outcomes are improved. There's also, from the economic point of view, the potential to decrease waste. So how often should a medication review be conducted? Well, that depends on two main factors: the age of the patient and the number of drugs prescribed. For a patient who's on 4 or less than 4 drugs and is aged over 75, an annual review is deemed to be conventionally acceptable. However, if they're on more than 4 drugs, then this should be at least every 6 months. So what should you consider when contemplating a medication review? Well, first of all, you should know what medications are prescribed, but in the clinical face-to-face review, you may then discover what the patient is actually taking. Does the patient complain of adverse effects? And this needs to be explored drug by drug. Has the doctor identified adverse effects that the patient has not attributed to the drug? For example, fatigue. A patient may ascribe to just one of those things and not assume that it's related to drugs, but it's a very common side effect of beta blockers, for example. And do the medications this patient is taking require monitoring? Do they require blood tests done? Do they require UZNEs done for ACE inhibitors, full blood count LFTs for methotrexate, etc.? And if they do require monitoring, how often should this be done? Are there obvious PIPs? Are there medications that can be stopped or switched to safer alternatives? Is it possible to change the regimes to once daily? Or, for example, concordance is known to be directly impacted by the frequency of dosing. So if somebody has to take 2 tablets 3 times a day, they're much less likely to be consistently concordant than on a once daily regime. Similarly, in the treatment of hypertension, combination tablets are now becoming increasingly used because they get the drugs into patients and control the blood pressure. They don't have to remember to take an additional pill, for example. The combinations of ACE inhibitors and calcium channel blockers are increasingly being used. To be safe and clear, so that all doctors involved with that patient know exactly what they're taking, you should record all drugs by their generic names. Also be aware that some drugs may be prescribed as repeat prescriptions in error. So, for example, in the initiation of treatment for hypertension, if you start a patient on, let's say, an ACE inhibitor such as ramipril, you would not put that on repeat for approximately 3 months, because by that time you will be sure that this patient has not had any adverse effects. But if that drug goes on repeat from day 1, and then within a month the patient has a dry cough, a typical adverse effect, but the drug is, although withdrawn, does not come off the repeat list, then an additional drug or a substitute drug is used, such as amlodipine. But when looking at this patient's repeat list of prescriptions, both ramipril and amlodipine will appear. And this is an error, so this should be avoided. Now let's look at PIPs. In summary, the PIP suggests that the risk or the harms of the prescription outweighs the benefits. They can be caused by a variety of things. The obvious one is overprescribing, but they can also be due to underprescribing or misprescribing. So let's look at overprescribing first of all. Generally, this is the commonest way that people suffer from PIPs, either with too many drugs, polypharmacy, excessive doses of drugs. So, for example, 5 milligrams of bendroflumethiazide instead of 2.5 for somebody with hypertension can give rise to more electrolyte imbalance, incontinence, hypotension, and potential falls. And in an older person, this is quite serious. There may be interactions with existing drugs. So if somebody's on warfarin, you should not start them in a non-steroidal anti-inflammatory because of direct interaction. Underprescribing is looking at lack of evidence-based prescribing. So, for example, a patient with a rheumatoid disease may be put on oral steroids because they at some stage in the past gave them benefit, so they want to continue with them, but they may not be on a disease-modifying drug. A misprescribing is where there's an unfavorable choice or dose or duration. So, for example, proton pump inhibitors should be prescribed in a healing dose. That would be 20 milligrams of omeprazole or 30 milligrams of lansoprazole for 8 weeks only. Then they should be stopped. And if symptoms re-emerge, providing there are no red flags, then that drug should be reintroduced in half the dose as a maintenance. However, it is very common to see people on full dose PPIs ad infinitum. And this is a big problem. In Ireland, the prevalence of potentially inappropriate prescriptions in the elderly is about 36%. But most of this is underprescribing. The main determinant of potentially inappropriate prescriptions, or PIP, is polypharmacy. So the likelihood increases with the number of drugs. It's also quite an expensive business. Total PIP expenditure in Ireland, when the study was done showing this prevalence of 36%, was 45 million euro. That is approximately almost 200 million ringgit. And that was 9% at the time of total expenditure on drugs in the over 70s. That's a whopping amount of money. The prescribing cascade is quite easy to understand, but many doctors fall into this trap. So just take the example of a patient who is age 78, newly diagnosed with hypertension, and he started an amlodipine. Some weeks later, he comes back for a review, and he mentions that his ankles have swelled up. The doctor misinterprets this as being edema and prescribes furosemide. Subsequently, he comes to see the doctor to complain of incontinence, that he has wet himself, he can't, and now he cannot go out socially because he's afraid of this happening again. The doctor now assumes he's a 78-year-old man, it's probably prostatic hypertrophy, so we'll give him something like alfuzosin, an alpha blocker for that. So here we have, within a couple of months, this 78-year-old man with hypertension is now on 3 drugs. When we look back at first review, what should have happened was that the amlodipine should have been stopped and changed for an alternative, such as an ARB or ACE inhibitor. The stop-start criteria are screening tools for the elderly to encourage safe prescribing. The STOPP criteria have quite a number of criteria which are all systems-based. The START criteria have fewer, but they provide explicit evidence-based rules of avoiding commonly encountered PIPs and PPOs. So what they aim to do is to improve medication appropriateness, prevent adverse events, and reduce costs. So here are the STOPP criteria, looking at them in their systems-based collections like cardiovascular and respiratory. That drugs have increased the likelihood of falls. That's very important in older people. CNS drugs, GI drugs, and musculoskeletal drugs. And you can see classic ones will jump out at you here, like warfarin and non-steroidals, benzodiazepines in the elderly, long-term opiates in those with recurrent falls, uses of digoxin in patients with renal impairment, thiazide diuretic and a history of gout, tricyclic antidepressants in people with dementia. Tricyclic have wide anticholinergic effects, so that cause dry mouth, cardiac conduction abnormalities, constipation, prostatism, urinary retention, etc. Using benzodiazepines at all in the elderly, but especially using longer acting drugs, these hang around in the system, and by the next day the person is very lightheaded, falls over. This may result in a fractured neck of femur, a fractured skull, and the implications are huge. Drugs used for diarrhea generally should not be used. Most episodes of diarrhea are viral and are self-limiting. Fluid replacement is adequate, but giving drugs long-term for recurrent episodes of diarrhea may lead to atonic bowel and ultimately to rupture with toxic megacolon. These are not recommended. As mentioned before, PPIs, proton pump inhibitors, should only be used for 8 weeks in full dosage. Theophylline should not be used as monotherapy for COPD, as well as being not as effective and not as safe as alternatives such as inhaled drugs. Theophylline also has the inconvenience of having to have blood tests done, blood levels checked. You don't need to do that with inhaled medication. These are the START criteria to alert doctors to the right or appropriate indicated treatment. And again, you can look at these yourselves. They're very similar to the STOPP criteria. What about drugs that are commonly used and are associated with preventable harm? Well, there are some drugs that have a very narrow therapeutic index. That means that the gap between safe and unsafe dosage is very narrow. So the classic ones would be digoxin, methotrexate, warfarin, and lithium. But there are other commonly used drugs also, such that also have preventable harm. So you need to be sure that your indication for aspirin and clopidogrel are sound. Ticlopidine has been included here. It's a precursor of clopidogrel, still used in Malaysia, but has been withdrawn elsewhere because of agranulocytosis. Diuretics, if not appropriate, can cause incontinence, electrolyte disturbance and falls. Beta blockers can cause fatigue and also can cause tiredness and other problems. ACE inhibitors in patients with renal impairment are problematic. And clearly, anti-epileptics, opioid analgesics, and psychotropics should be prescribed with caution. Similarly, with non-steroidals, oral steroids, insulin, metformin, and sulfonylureas, your indications for all of these should be sound. There are other criteria, such as Beer's criteria, an American set of criteria, which also identify potentially inappropriate medicines. These have largely been replaced by the more detailed and more specific stop-start criteria. So let's look at a sample medication review. This is Mrs. E.T. She's age 75, and these are her diagnoses: asthma, osteoarthritis, and osteoporosis, and with a proven hip fracture some 3 years earlier. These are the medications she is currently taking: salbutamol and beclomethasone inhalers, lansoprazole orally daily, diclofenac orally twice daily, and calcium and vitamin D 1 tab daily. The question for you is, what would you discuss with Mrs. E.T. during this medication review? So let's look at this review and what you would ask. You want to ask, you can see what she's been prescribed, but is she taking these? And is she taking these regularly? And when does she take them? And is she consistent in doing this? These are difficult questions to ask. So instead of barraging this lady with questions and interrogating her, you may say to her that many people find it very difficult to take these medications regularly, and I'm wondering if you ever find any difficulty with that. She may then open up to this and tell you that occasionally she forgets it, and then you can explore that and probe it and find out as clearly as possible how often she is concordant with the medication. As two of her medications are inhalers, salbutamol and beclomethasone, you might want to assess her inhaler technique. You might want to provide her with a spacer. Most people, and particularly most elderly people, using beta dose inhalers have incorrect technique and they lose most of the drug. A spacer will prevent all that happening. You may question her on her understanding of why she takes the medications. Most people don't know why they take the medications. They say they only take them because the doctor prescribes them. But in terms of understanding what each medication is and why they are taking it, most people do not know. And that's a challenge for us to educate our patients appropriately. What about adverse effects? So common adverse effects, she's taking diclofenac, could she be getting gastritis, duodenitis, indigestion? Does she get oral thrush? She's on a steroid inhaler. She may need advice to use a spacer and also to wash out her mouth after using her beclomethasone inhaler. Does she get constipated from the calcium? We also want to look at monitoring. Now, monitoring doesn't just imply blood lab tests and so on. It might look at asthma control. What's her peak flow? Does she have a peak flow meter? Did you prescribe one? If not, prescribe one and then monitor this regularly. Inform her of what levels of peak flow are okay and what levels are unsafe. She should have an asthma action plan built into this as part of her monitoring. Is there a clinical need for lansoprazole at full dose? And if she does still need it, then does this suggest that something underlying needs further investigation? Does she need an upper GI endoscopy? She's on a non-steroidal. There are two issues here. These drugs cause upper GI disturbances in the elderly people particularly, but also increasingly now we have become aware that they cause cardiovascular harms. So they lead to fatal and non-fatal cardiovascular events. Myocardial infarction, for example, unstable angina can arise de novo in an elderly person because they're taking a non-steroidal. This also applies to drugs such as celecoxib, etocoxib, and these other drugs which were regarded as being relatively less harmful. It now turns out that this is not the case. They are equally harmful and causing cardiovascular events. Does she need lab monitoring for using these, for example? If she's on a long-term PPI, does she need checking in her magnesium level? If she's feeling fatigued, could this be the reason? What about interactions between her asthma and her non-steroidal? Some people, this causes a severe reaction. Not in everybody, but it's certainly worth exploring that. And if there's a safer alternative to the non-steroidal, which does not impact on her asthma, then this should be chosen in preference. Can the NSAID be discontinued or swapped? And does she need a full dose PPI? One other consideration you look at in medication review, you're looking at the drugs that are prescribed, but you might also want to consider the drugs that are not prescribed. So, for example, she's on calcium vitamin D3 for her osteoporosis, and bearing in mind she's already had a fracture, the best evidence for prevention of further fractures in this age group with that medical background would be bisphosphonate, yet she is not prescribed a bisphosphonate, but she should be. Here are some references for you. There's a section on chronic disease care and the elderly in the Oxford Handbook of General Practice. Here's a link to that. Quick Medicine app also has several sections around this topic, including non-compliance. And these are references to the papers relating to the prevalence of potentially inappropriate prescribing in an Irish population. And finally, the Choosing Wisely campaign from the United States looks at drugs and other devices and so on, and encouraging doctors to choose wisely so that we don't use harmful medications. Thank you.